deep margin elevation simplified clinical approach. I want to start by thanking our sponsors, Colteen, Kerr, and Oral Arts Dental Laboratories for your continued support. Without their support, these free webinars will not be possible. I also want to direct all our audience to our YouTube channel, Romero Dental Seminars. Please don't forget to subscribe and share our videos with other colleagues. As you all know, our content is 100% free, so please take advantage of that. I also want to remind everybody our new book, Minimally Invasive Aesthetic Dentistry, The No Drill Techniques, is now available visiting the Quintessence Publishing webpage or shooting with your iPhone or Android this QR code that you have right here. You take a photo of the QR code and it would automatically take you to the different websites Quintessence has all over the world for you to be able to order this book. I hope you enjoy it and thank you for your support. So today's objectives are going to be very simple. First one, highlight the different clinical options for deep margin elevation. Review the clinical steps recommended using my simplified approach, and highlight the clinical steps in a real clinical situation. So let's get started with objective number one. Highlight the different clinical options for deep margin elevation. Now, deep margin elevation, as you all know, it's a very hot topic. You know, there's a lot been said about this. This is nothing new in restorative dentistry. And for me, it just has become a little bit complex the way that we elevate our margin because there's so many techniques out there. So what I really wanted to share with you is my, I don't know, 10, 15 years experience doing deep margin elevation and kind of walking you through different clinical scenarios and clinical techniques that are out there for you to, create or elevate a deep margin. And at the end of my presentation, my goal is to try to simplify all this and try to walk you through the process of how to use one or two systems out there that with a special step-by-step technique that I use in my practice, it would help you make this a little bit more, a little bit more simple, the actual clinical sequence. So one of the things that you can use in order for you to elevate a deep margin, as we all know, is just a regular Toffel-Meyer band. Now, these bands, they have their good and bads. So the good thing, they're easy to acquire. You can buy them everywhere. They're not expensive at all. And, once if you're able to push this band very, push it apically, you will be able to elevate deep margins. Now, sometimes you're going to have to modify these bands, and normally you would modify them. Let's say that this preparation here that you're seeing, this is one of my cases. You can see how deep that mesial margin is. So in order for me to be able to push this band more apically, I may need to cut a little horseshoe shape type of modification on the distal part of the band so that the band can sink more and then be pushed more towards the deep margin on the mesial. Now, in this particular case, I did not have to modify the band at all. I was able to push the band apically, and the band was able, as you can see on the photo on the left-hand side, I was able to, to sink it enough for me to have now complete control of that mesial proximal box, the deep box that you see there. And then using composite resin, I was able to elevate that deep margin using this simplified technique. Now, this is easy in some cases, but it's not usable in every case out there. So, you may be able to get away with using a regular Toffel-Meyer band in some of your cases, but definitely it's not going to be a band that you're going to be able to use repeatedly or in multiple different clinical scenarios. So for that reason, some years back, there was this band that was created, which is a deep margin elevation Toffel-Meyer band. And this band actually comes in two different presentations. You can buy it the way that you see it right here on the left-hand side. And there's many companies that make them out there. This one specifically is made by Garrison, but there's a lot of other companies that make this type of deep margin elevation modified Toffel-Meyer band that can still be used on a regular Toffel-Meyer band holder. But you can also have, Garrison makes one that comes with a special tool that you have to kind of rotate so that the band can be tightened around the tooth. So this would be a retainer-less system. Now, in order for you to be able to purchase that system is it can be, can be expensive. And I have found that the system is not good for every case either. So you have this, you have this investment that you have to do in order for you to have this in your practice. But at the same time, you're not able to use it in every single clinical case. So for me, this is a good system because it's already modified for you. It's a lot easier to be able to push it apically, but again, it's not made for every case. Now, in the case that I'm sharing with you right now, you can see that I'm using one of these modified bands. These bands are very, because they've been modified, they've been cut, as you can see here on the occlusal end. These bands are very short from the gingival towards the occlusal. They're very, very short, maybe a couple of millimeters, which in turn gives you the idea of where the increment should be located and how deep that increment should be. Because if the band is 2 millimeters and the band is literally placed in the deep margin, you know that when you add composite, your composite is going to be 2 millimeters thick. So it also helps you with controlling the thickness of your increment, which is great because you don't want to place an increment that is greater than 2 millimeters and then have a problem with polymerization of your composite on that deep aspect of your box. So in this clinical case, in the photo in the middle, I'm sorry, let me go back one. You can see that I've already elevated the deep margin on the distal proximal box of this MOD preparation. Now I'm going to do the same with the mesial deep margin. And then I just go ahead and remove the band, remove this deep margin elevation band, and continue using, whatever band you want to use, depending on the type of preparation or the type of, restoration that you want to, complete this case with. You could be an indirect restoration, like an onlay or something like that, or you can do just an MOD composite, whichever type of final restoration you use for a case like this. But again, this is a good option, but it limits your clinical applications because I have had issues. If you use the ones that I use, which are not retainerless, you have the weight of the retainer, the band retainer, that actually can kind of move this little band or not allow the band to fully sit around the margins. Now you can arrange or you can correct that by using a wedge. But the wedge can also alter or modify the shape of your band. So again, there's a lot of questions and answers that need to be asked. And that's why my goal is to try to present today a way of obtaining this same type of result using a little bit of a different clinical approach. Now, the other band that I also recommend for deep margin elevation is the saddle matrix band. Now, in this particular case, I am going to elevate that deep margin that you see on the mesial of that mesial box. I'm going to elevate it. I'm going to use this saddle matrix area, but I'm not going to use the saddle matrix retainer. So for this particular case is I was able to introduce the band, insert it, push it. You can see that the band has a gingival extension, which is great because it's a lot easier for you to get to these deeper margins. But then I needed to use, as you can see there, multiple wedges to kind of secure the band in place. So I wasn't able to use the actual holder for this saddle matrix, but I was able to customize a way of keeping the band in place by using multiple wedges. Now these bands, what I like about them is that they're very rigid, and because they are rigid, you can see that even though that I've used multiple wedges to kind of approximate the band to the remaining tooth structure, the band there's no alteration of the shape of the band. And again, that has to do with the stiffness of the band. So this is a good clinical scenario where you can use a saddle matrix band in order for you to elevate the margin. But again, they're not made for every single case out there. So now let's go to objective number 2, and let's review the steps recommended using my simplified approach and also using a fairly new system that's out in the market now called the quad matrix system by Garrison. Now, when I have cases like this, you can see that these two proximal boxes, this is a really complicated case. It's a difficult case to restore, not only because the boxes are deep, but also because the boxes are wide and there's one facing the other. So it's a back-to-back type of clinical scenario. And these are the more challenging clinical scenarios that we are confronted with. So for a case like this, where I can see that my proximal boxes are wide and deep, and there's two of them, one right next to the other and one facing the other, I'm going to make my selection is always going to tend to be for the 3D Fusion firm matrix band. Now, these firm bands are thicker than the 3D Fusion bands, the 3D Fusion bands that are color coded and that have Teflon inside. But these firm bands are more, they're stiffer. Now, why am I saying this? Why am I making this? Am I making you aware of this? Because if you think about it, if the band is stiffer, I'm going to need to create a little bit more pressure with my wedge and with my ring in order for me to create a little bit of orthodontic separation between these two teeth, and then not only be able to recreate my proximal surfaces, but most importantly, recreate a tight interproximal contact so that I don't have any food packing and then secondary decay as a as an or as an issue that may show up sooner rather than later because of that soft or slightly open interproximal contact. So keep that in mind. I love these bands and I love them for this particular case. And I'm going to share with you a different way that I do this, for a different clinical scenario where I would decide to use maybe the 3D, the 3D tight fusion band, the color coded ones that have the Teflon inside. So again, this is when I would use these bands for a case like this. Now you are seeing right here that I was not only able to place both of these stiffer interproximal bands, but then I have to choose the right wedge. And the quad matrix, I do like the system. I don't think it's made for every single case out there. I want to put that out there. I don't think that this is the only system that you need to have in your office. You're going to need to have a couple, and I do have a couple of Garrison systems in my office because again, I like this system, but I don't think that it's made for every single case out there as well. So again, it's one more of a system that I have as an armamentarium in my practice. Now, for this particular case, because I told you that I was going to use these stiffer bands, you can see that you have 4 different sizes for this quad matrix system, and I have used the quad wedge, the orange quad wedge, which is the second in size. So this is going to give me enough contact tightness, is going to give me enough pressure in between these bands in order for me to be able to recreate that contact tightness that I want when I add the force created by the wedge as well as the force created by the ring. Now, what I like about these wedges is this split system here. I think it was ingenious by the person that invented this. You can see that he split the wedges split in half so that now when you place the ring, half of the wedge goes mesial, half of the wedge goes distal, the other half goes distal, and helps with adaptation of the band so that you have an ideal lingual embrasure. So keep that in mind. That's one of the things that I like about the system, and that's one of the things that the wedges does for you. Now you can see here that this is a different case. Now this is not a back-to-back case. Yes, this is a deep proximal box. It's a wide box as well, but you can see that there's ideal or good proximity between this tooth and the tooth distal to it. So I don't have a large interproximal space. So when I have cases like this, I'm still going to use my Garrison system, but I'm going to use now the 3D Fusion green band. Now, why do I select the green band even though this tooth is a premolar and the green band is better designed for molars? Well, the reason why I like this green band is because of that gingival extension. You can see it right here. This is a very tall band. And the reason why I like using these two systems, either the quad or the 3D Fusion system for these deep boxes, is because in both cases, the wedges are made out of a very soft plastic. A soft plastic that when you insert the wedge, you do not deform the band. And that's what I would recommend you use when you are using the 3D composite tight system. The band, this green band with the extension. You can see here that I have chosen to use the medium band, which is the blue one, and I've now inserted that blue band. Now, by inserting that blue band, you can see that I get a very nice or beautiful adaptation actually of the band in this deep box, but without damaging or altering the auto the normal contours of the band, the contours that are already inherent inside the band. So they're created by Garrison. That double contour that the 3D band has is kept because this wedge has these little spikes that are made out of rubber. They're very, very soft, and they're only meant to again adapt the band. They're not meant to deform the band, because you are going to get that contact, that interproximal contact tightness, given by the additional force of the ring on top, in the buckle and the lingual embrasures, as you are seeing here in this photo. So it's a combination of all these things that give you that ideal interproximal contact tightness. So now let me go ahead and highlight the clinical steps in a real clinical situation, so that you can see how am I using and what I recommend today you use for your deep margins. Now I'm trying to stay away from using a sectional matrix, or I'm sorry, a Tuffle-Meyer band, or a modified Tuffle-Meyer band, or one that I modified myself. I'm trying to stay away from the saddle bands. I'm trying to simplify this and give you one clinical solution for every case out there. And the case that I'm going to present to you today, the ones that I presented to you today, are very deep and wide proximal boxes. So as you know, these are not easy clinical scenarios. And I'm sharing with you in these clinical scenarios, you can see the photo on the left. I've already accessed my preparation. I've accessed the cavities. And now I'm going to go ahead and I'm going to remove all the infected dentin and the demineralized enamel using my caries detection dye, so that I can make sure that I end up having a clean peripheral seal zone. Now, not only that clean peripheral seal zone is important, as you are seeing here from photo A to photo B, but also I want you to observe how I was able, by using a very fine diamond burr, like an 8888, or a fine a needle type of burr with a red stripe, meaning a medium grit diamond. I'm going to go ahead and I'm going to go ahead and bevel all my margins, mainly the buccal, the lingual, and the gingival margins. All these margins are now beveled. They're nice and smooth, because that also has a lot to do with the ideal adaptation of the band in these proximal boxes. And not only the ideal adaptation of the band, but also the ideal adaptation of the composite to the band and to the bevel enamel. Now, why bevel enamel? Because we all know that in the bevel enamel, you have now sectioned the head of the enamel prisma, and you're going to get a better bond strength in those areas. So there's a lot of things playing an important role in these bevels that you see that I've created in those two proximal boxes. Now, once I've created the bevels, I place these Tuffle-Meyer, I place these Garrison bands. These are the stiff Garrison band. Again, these are, I'm choosing to use the stiff ones, because this is a wide interproximal preparation, a deep preparation, but also there's a back-to-back component. So you have a really wide space that you need to restore. And for that, you want to make sure that you use these stiffer bands that are going to give you more, they're going to be more resistant for you to recreate, push these bands towards one another, so that you can get a very nice contact, but most importantly, a very nice and anatomical contact. So here I chose to use those stiffer wedges, and at the same time, I'm sorry, stiffer bands. And now I'm going to use the medium wedge, the medium quad wedge. Now you can see that this medium quad wedge works very well with this quad matrix ring. Now the quad matrix ring either is blue or yellow. The blue is a shorter one, the yellow is a taller one. The reason why I chose the yellow, of course, I have very wide and deep, I have deep proximal boxes, so I want to make sure that there's more of this rubber tip that's surrounding my band, so that I can get and recreate the ideal shape of these proximal buccal and lingual embrasures. So the most important thing is that the openness of the wedge, the split tip of the wedge, goes always to the lingual, and you will also place a ring. So there's a right and a left-handed ring. A right side and a left side ring, and you know this because of this little arrow that is literally tinted with this black tint or black marker on the lingual side. So this is the portion of the ring that goes in between, that needs to split the wedge, buckle, half of the wedge to the buckle, half of the wedge to the lingual, so that you can see that it recontours the band. Now, when you are seeing this photo, when I noticed this, when I was doing this case, you can notice that the distal band, or the band that's restoring the mesial box of the first molar, has much better adaptation than the distal band placed on the premolar. You can see that on the lingual aspect of this band, the contact, I mean, the band is not adapted correctly. Now, the reason why this happened is because both of these proximal boxes were very, very large. So what did I decide to do clinically? I did not remove the ring. I decided to go to restore one of these boxes at the time, because I knew that if I did them both at the same time, I was going to have a lot of excess towards the lingual. So you can see that I've added that I'm going to restart, and I'm going to start restoring first that first molar and the proximal contact on that first molar. So I acid etch, I do selective enamel etching here, and then I'm going to use my 2-bottle system. For this case, I use OptiBond Extra Universal from Kerr, and that's my go-to adhesive system in my office. And I'm going to do that on the dentin, the primer, and then I remove the excess primer and the solvent with a little bit of air after maybe 15 or 20 seconds of dwell time. And then I go ahead and apply 2 to 3 coats of my adhesive. All this after, again, before I did this, I did selective enamel etching. Before that, I actually cleaned both teeth with my AquaCare system. Then I went ahead and rinse and dry, do my selective enamel etching, rinse the enamel etching, and then I go ahead and do chlorhexidine, dry the chlorhexidine, and then go ahead and do my primer and adhesive and light cure. Then I do my resin coating layer, and then I'm always going to do first a horizontal layer. Every time you have a deep margin, you want to start by putting a horizontal layer that goes from mesial to distal, from gingival to 2 millimeters of the height and the occlusal aspect of that first horizontal layer. Make sure that you tap on it, that you condense it nicely. I take my time because it's critical that first layer is completely adapted to the floor of the box. And I'll show you when I start restoring the premolar how I was able to, how that goes, because in this case it was a little bit complicated. So I already did the horizontal, and then I did my proximal layer, so that I now have a class 1. And then after that, I reinforce the tooth with a fiber. I do my horizontal layer, and then my successive cuts build-up technique. And then I'm going to go to the second tooth. Now, on that second tooth, you can see that I've already I went ahead and removed the ring, remove the wedge, and remove the band on the premolar and on the molar. And then place the band again only on the premolar. And now you can see that the adaptation of the band and the way that the ring is pushing the band is much better than the first time that I applied it. That's why, again, I decided to do both of these back to back individually instead of doing them both at the same time. And again, it all depends on how good adaptation you think or you feel you have when you're doing these cases. And every single one of them is going to be different, as we all know. So again, AquaCare, I'm going to go ahead and clean, rinse and dry. Then I'm going to go ahead and put my selective enamel etching, rinse and dry, chlorhexidine, dry the chlorhexidine, and then start placing my primer, my adhesive, light cure, do my resin coating layer, allow it 4 minutes to mature, and then I'm going to come back, and you can see now I've placed my first horizontal layer, 2 millimeters thick from buccal to lingual, touching all that gingival floor, so that I know I have ideal adaptation of this first critical layer. Now, when I do this, I'm pushing that with a condenser, and then I use a micro brush and I wet it on my adhesive only, and then I start pushing that layer again. I take my time, I take maybe 30-40 seconds. I'm just playing with this to make sure that I'm pushing it enough to get intimate contact in between that layer and the gingival floor. Once I feel that I'm ready, that I've done enough, I go ahead and light cure, and then I come back and do my proximal wall. That's what you're seeing here. This proximal wall is the second layer right after that first horizontal layer. And I make sure again that it's adapted beautifully to my buccal and my lingual walls. That enamel in that area was, for a reason, beveled. This is the reason why we want ideal adaptation. And again, I start now playing with a little brush, an artist brush that I use, a very small one, and a little bit of adhesive, and just kind of pushing this layer towards the band, towards the buccal, towards the lingual, and towards the gingival floor. Again, my goal is to get beautiful adaptation of this. Then after the brush, I use a micro brush with a little bit of adhesive. And again, just push, adapt, make sure that everything is in contact so that I then can go ahead and light cure and then do my final horizontal layer, my buccal, my lingual layers. And you can see now I've completed the second restoration. So now that both restorations are completed, you can see how nice and wide from buccal to lingual and from gingival to occlusal, how nice and wide and anatomical I was able to recreate that interproximal contact, even though there were two very deep interproximal boxes. So I know you have these cases in your practice. I know that this clinical approach using this Garrison systems, both either the 3D or the quad system, are going to be very helpful for you in your clinical in your daily clinical practice, because we do class twos almost every single day in our office, and I don't think that your office would be any different than from ours. So then all we have to do is remove all the excess, make sure that we polish, that we check the tightness of our contact, that we adjust occlusion, and then finish and polish our restoration and send our patient home. I hope that these very nice and well described clinical tips help you in your everyday practice. And I also hope to see you not only revisiting my channel, but to see you on our next webinar, where we're going to share with you, like always, very useful clinical tips that you can use in your everyday or your daily dental practice. Have a good rest of your day. Thank you for watching.